Hi, I'm Maria, gastroenterologist at Royal Adelaide Hospital. On behalf of my colleagues, I would like to thank GRE for the opportunity to discuss about our article entitled The Effectiveness of CAP-Assisted Device in Endoscopic Removal of Food Bolus Obstruction from the Esophagus, a Single-Center Experience. Food bolus obstruction is a common presentation to emergency department, and approximately 20% of cases require endoscopic removal of food bolus. There are a variety of endoscopic retrieval devices available, including net retriever, polypectomy snare, Dormier basket, grasping forceps, and tripod graspers. The choice of endoscopic devices depend on device availability, the type and size of food bolus, as well as location of food bolus obstruction within the esophagus. However, endoscopic food bolus removal can be challenging due to a restricted endoscopic view and a limited working space within the esophagus. Food bolus can be removed in either an en-bloc fashion or a piecemeal fashion. Recently, a study conducted showed the use of transparent cap to be effective in retrieval of esophageal foreign body. However, data on the use of a cap in food bolus obstruction is very limited. We hypothesized that the use of a cap-assisted technique would also be effective in removal of food bolus obstruction from the esophagus. Our study aimed to assess the effectiveness of a cap-assisted technique compared to conventional techniques in removal of food bolus obstruction. The study was conducted at our center at Royal Adelaide Hospital, which is a tertiary referral center for acute food bolus obstruction. We decided to conduct a prospective, non-randomized longitudinal study over a 6-year period to assess the effectiveness of the use of a cap in removal of boneless food bolus within the esophagus. We recruited patients who underwent an endoscopy for food bolus obstruction between 2011 to 2016. The measured outcomes were procedure time, success rate of food bolus extraction, rate of en-bloc removal, procedure-related complications between the two groups. Cap-assisted technique involves the use of a transparent cap fitted onto the tip of the endoscope, similar to the caps used in esophageal variceal ligation and endoscopic mucosal resection. On the other hand, conventional techniques involve the use of either a single or multiple devices, including a snare, a net retriever, a tripod grasper, and a biopsy forceps to remove food bolus obstruction. The choice of endoscopic devices used to remove food bolus was at the discretion of the endoscopists. If the initial conventional techniques failed to remove food bolus, the same patient was crossed over to the cap-assisted technique and vice versa in an attempt to extract food bolus. After removal of food bolus, all patients underwent an endoscopic assessment to evaluate for any underlying esophageal pathology as well as procedure-related complications such as mucosal tear, perforation, or bleeding. The conclusion of our studies was that a total of 315 patients were recruited into the study who underwent an endoscopy for food bolus obstruction, of which 199 patients required the use of an endoscopic retriever device to remove food bolus obstruction. A total of 93 cases used the cap-assisted technique and 106 cases used the conventional techniques. Our study found that cap-assisted technique was more successful in food bolus extraction compared to the conventional techniques, and the use of cap-assisted technique was associated with shorter procedure time and a higher rate of en-bloc removal, as well as a shorter length of hospital stay, and these differences were statistically significant. We also looked at procedure-related complication observed between the two groups. 5 patients had a localized esophageal mucosal tear associated with minor bleeding from the use of a snare. None of the patients required any blood transfusion or endoscopic intervention to achieve hemostasis. And 2 patients experienced oxygen desaturation at the end of the procedure from suspected aspiration pneumonia. There were no deaths in the cohort. So in conclusion, cap-assisted technique has been found to be effective and safe in removal of boneless food bolus obstruction from the esophagus. This technique was associated with a shorter procedure time, a reduced length of hospital stay compared to conventional techniques. This finding has led us to conduct a multi-center randomized control study to validate the effectiveness of CAP device in removal of food bolus. I hope you enjoy reading our article, and I'd like to thank my co-authors for their contribution and for all of you for watching this video. Thank you.